अनम्यूट कर लो, अनम्यूट कर लो। Anvita, unmute yourself.
Hello, good afternoon.
Good afternoon, Anvita. कैसे हो आप? All good?
I'm good, sir. How are you? All good, sir.
Great, great. So we're starting in 5 minutes. Yeah, there will be then 2 cases and both are infectious actually. So we need your inputs from there, right? Okay.
They sound really sick, sir. I'm very excited.
Right. हमें talk नहीं आता। चलो ठीक है। Okay, we'll start Anvita and we'll take your inputs. Okay.
Sure.
Good afternoon, everyone. I welcome you all to the monthly scientific meet. So the first case for today is an unusual presentation of dengue fever. Presenter is Dr. Ajay Krishnan, second year DNB resident, Max Super Speciality Hospital, Vaishali. The case will be moderated by Dr. Pankaj Chaudhary, and the case will be chaired by Dr. Ashok Grover and Dr. Naresh Agarwal. I request Dr. Ajay to start with the presentation.
Afternoon. I think in the Delhi season.
Okay. Slide open you.
Little late today to the distracted. Still. Playing the kind of wicket. So it does one time. So we definitely had a couple of cases where we thought that we'd share with the friends. But they did give us certain issues with a lot. So I think we discuss these things as we go along. That every time has got something to teach us. I think Ajay is not here completely.
So there are a lot of residents are on leave, so there's no scarcity of residents. So Ajay is stuck up with the ER, so I'm representing. So these are the our cases, and I actually posted in the group in the morning as well. Say how you are seeing dengue now, right? Is it different or is that the same? But the one thing that I saw that the cases are a little less this year. You must be agreeing to that. There's no so much of tsunami over dengue cases that we used to have. But now, yeah, off late, after 3 to 4 days, I think off late they're coming out. Maybe some late surge in this, and we didn't have so much of rains also, probably. So there must be some reasons behind it, and since those are viral illness. So yes, it's good at times because festival times, and wish you all happy Navratras. I think that's good. So today is Sapni, and may God bless you all with health and happiness. Goddess, Ma Goddess. And I welcome Dr. Naresh Agarwal. Naresh को बुलाना पड़ता है बस. तो हमने कहा बस.
This time, hepatitis A and entry.
Right.
That too,
Yes. So 8 entry fever, and I think Shashti is here. She will be presenting annual case of complex case of fever. So there are a lot of mix up of infections. Yes, hepatitis A, entry fever. In fact, chikungunya was not there for 3 to 4 years, and we are seeing chikungunya now, right? As Dr. Rajimasan rightly said. So we should be aware of that. There's a lot of unusual presentation of viral infection, be it dengue, be it. In fact, yesterday we admitted one patient of malaria after a long time, and in the same patient, both Vivax and Falciparum positive. Platelet count 25,000, and she was in DIC with early RDS. So both Vivax and malaria both were there, right? So this type of infection that we used to see nowadays. So I'll present just 2 short cases, and I'll take your opinion that how you experience. And I welcome Anita also. She is joined from Gangaram, so she could not get leave from Gangaram. So I thought that she would join, and definitely we'll have inputs for Anita. Okay.
Thank you so much, sir.
Right. Okay. So this is a 51-year-old female patient. She's a resident of Delhi. She was admitted just now on 25th of September 24. She came to the emergency room with complaint of high-grade fever for past 4 days, multiple episodes of vomiting and pain at all for past 4 days. So this is, I think, typical presentation of dengue sometimes. Normally the patient presents dengue as such. Sometimes the patient presents with rash or no rash, but the usual presentation is there. Very high-grade fever, 103, 104. Right? If you go to the HOPI, the brief HOPI, that patient presented with complaint of high-grade fever since last 4 days. Fever intermittent nature because patient used to take PCM, SOS. Fever was associated with severe headache, retrooptical nature. No chills, night sweats, blood of vision, neck pain. I think there are no signs of irritation over there. Patient developed abdominal pain for past 2 days, was more acute and more on the epigastric region. And we see a lot of dengue patients coming with epigastric pain and all. Patient also complained of multiple episodes of vomitings, nausea, preceding vomiting, and no blood in vomiters. There was no history of burning maturation, no blood injury, no rashes, no recent travel outside, and no recent food intake from outside, as we used to ask with every patient. So I want to ask one question, Dr. Naresh, that in dengue patient, what would the usual cause of abdominal pain? Sir, Mike. Mike.
maybe because of polycystitis or polycystic.
Right.
That's the usual cause of pain. Although you've never seen severe pain being presented as severe pain in dengue.
Right. So a lot of pain is there, maybe because of, you rightly said that when you do ultrasound, you get, gallbladder wall edema and acalculable cholecystitis, you rightly said, is called pain. Maybe some liver enlargement is there, hepatitis, sort of dengue hepatitis that can cause pain. And some intra-bowel fluids, sometimes patient comes with polycystitis. So stretching of, this bowel can also cause, like used to give diffuse pain in abdomen. So generally the patient used to come like this. So this is we also thought of that, right? So past ministry patient was hospitalized 1 month back in Pushpali Medical Center with some LRTI pneumonitis and was completely recovered from her illness. And no history-diabetes or hypertension, no chronic illness, and patient was not on any medications. And when we examined the patient was fully conscious and rotated. Respiratory system examination, few bilateral basal fine crepitations could be the sequelae of the past infection that she had pneumonia 1 month back. Cardiovascular system was essentially normal. For abdomen, we use soft tenderness. Tenderness was there, marked tenderness was there in the right hypochondrium and epigastrium. And liver was just palpable with smooth margins, and it was a little tender, non-tenderness or mild tenderness was there in the same. And bowel sounds are present. This is the typical picture that we used to see, right? So when we get this hemogram, hemoglobin was 13.9, TLC was around 12,300, and you can say differential it. Neutrophil 26. Sometimes when we see the TLC, high TLC, we tend to start antibiotics. So actually, we should see the DLC also at times, right? So in this case, neutrophil was 26%, lymphoma was 33%, and monocyte was 40%. It is the monocytosis, and it's very common in patients of any viral illnesses, right? Be it dengue or be it any viral illness. PCV is 48. It's very important. PCV is very important dengue because the most important treatment of dengue fever is fluids and fluids, right? So PCV 48 high, platelet count was around 45,000. NS1 and IgM both were positive, and SGOT GPT, and we said that SGOT is more than SGPT in patients of dengue fever, and it was there in our patients also. And bilirubin was mildly raised of 1.9 with 0.9 and 0.3. So this is a classical picture that we get: thrombocytopenia, mild transaminitis, high leukocytosis with relative monocytosis. This we get, and hemo 30.9 and PC 48. So this is the picture, and treatment is definitely supportive. You have to rush fluids in these patients, and most of the patients get better. So on examination, vitals were stable, right? So there was no hypertension or something like that. There was no tachycardia, right? But patient was concerned only for severe abdominal pain that actually she was having. So routine we get this ultrasound, right? So as Dr. Nash has said, that most common cause of this pain abdomen is because of polycystitis or because of acalculable cholecystitis. So we just have ordered an ultrasound. Patient had a history of post-op lab poly. Patient had a history of lab poly post-op, right? So gallbladder has already been removed, right? So that the thing was actually out.
For severe pain, to focus your investigation on fever. What did you investigate for severe pain?
Right. So right. So our epigastric patient coming with epigastric pain, my diagnosis definitely would be pancreatitis, right? Patient may present with acute pancreatitis, but actually patient already have a dengue also. So we don't think of pancreatitis in that particular patients with some stable vitals and other organs are fine. But yes, acute pancreatitis is one of the differential diagnoses. Then acalculable cholecystitis is the other one. So definitely we need to go to the to an ultrasound. Yeah. No, I would say it's not a leukocytosis. You can see the differential. It is monocytosis basically. What?
Yes. And it is not always monocytosis. It is lymphopenia.
Sir, I am saying that what the patient can present with. That is sometimes we get the atypical presentation, and that is we have atypical presentation of dengue. Normally we get like lymphopenia. This leukopenia very common. We have seen in dengue 1.1, 1.2 TLC, right? So it is not very filled, but this is this thing 12,000. Right.
Apart from there, we should think of some secondary.
So day 4, day 5 of illness. Sir, at day 4 and day 5 illness, definitely. Leukocytosis with neutrophil of 26%. I would not say it's a full-blown bacterial sepsis. It could be other infection as well. But we could not think of some bacterial infection on day 4 and day 5, right? And if you think of pancreatitis as well, because pancreatitis can also cause this leukocytosis. Pancreatitis. Sir, actually, we don't do this typhoid and viral, we just do the blood cultures. And ultimately, blood cultures came out negative because we get a lot of typhoid positive, negative, that wouldn't make any sense.
Then see, maybe there's also because of the relative near which you really more important. Initially, most of the patient at emergency, they are take the sample.
So patient is having recurrent vomiting, pain at abdomen, may not be not taking orally, then it is relative or relative. Dr. Vijay said that normally of dengue patient we used to see leukopenia itself, but that we can always discuss. Right. So secondary infection, right? And some dehydration when because hemoglobin is 13.9, maybe dehydration, PC is 48, right? PC 48 means that it is patient has severe dehydration. Let's see, we give fluids and the things becomes, may settle down, right? Okay. So ultrasound was done on 26th and showed hepatomegaly with grade 2 fatty infiltration. Spleen was there, mild hepatomegaly, but though very minimal. GB was not visualized, post-op status. Visualized pancreas appears bulky and mild heterogeneous in texture. Tail of pancreas obstructed by bowel gases. So there is suggestion of minimal fluid along the head of the pancreas, and we are suggesting pancreatitis. So I think, Naresh, I think with this ultrasound and with this findings, so diagnosis of acute pancreatitis is on the cards. The CBD normal things.
So what was
Dr. Anita,
alkaline phosphatase?
LPA, GTP, no,
Alkaline
I have written only the positive findings
phosphatase.
because of two small cases, some positive findings. ALP and GGT was normal in this case. So there is no signs of any obstructive picture.
No, day 3 and day 4, ultrasound usually does not pick up any abnormality in acute pancreatitis. So it is bulky, maybe suggestive of acute pancreatitis.
So,
But in a patient with severe pain, epigastric and tenderness, in all investigations, amylase like this.
yeah. So actually, patient turned out to be not on day 3. Patient actually had fever for 4 to 5 days. She was in this home itself, taking paracetamol. He came to on day 6 actually. Jab fever settled होने लगा था उसका. Then she came actually, but of pain and vomitings. So after I think 4, 5 to 6 days, you can get some in ultrasound. And so I think this is cannot be right. So I would not say that CT is advisable. I think that amylase lipase would tell us the story.
Amylase like this,
Right. So we did amylase lipase, and you can see the serum amylase was 1222 and lipase was 5341. So I think the diagnosis comes, and if you make a diagnosis of acute pancreatitis, the amylase lipase should be in the tune of 3 times more than the normal values. Right. So this is very high. The patient is having dengue fever, NS1 IgE positive. Patient with abdominal pain, post-op status of orbiter, present with thrombocytopenia, dehydrated state, and severe abdominal pain, suggestive of acute pancreatitis. So when we look at literature, I didn't see any much of the cases of patient dengue fever with acute pancreatitis. Not much. Yeah, they are sir. अभी literature है sir. सब कुछ है. लेकिन normally क्या होता है जब patient आता है, then we think that it is acute and all, because normally सारे patient pain करके आते हैं. So we don't suspect acute pancreatitis in every case, right? So in this particular case, as we could get, or Dr. Naresh was rightly said that 3rd, 4th day you can't pick the pancreatitis in ultrasound. So I think my take home would be that if the patient is having some pain, epigastric pain, so we should do at least amylase lipase in every patient, just to have the with acute pancreatitis. That was actually my message. Yes. Yes, it's very common acalculocholestasis. Absolutely. So diagnosis, final diagnosis, dengue fever with thrombocytopenia with pancreatitis, and is any treatment difference from acute pancreatitis in patient with dengue or non-dengue, Dr. Naresh? Or treatment with this? Is any difference of treatment between dengue and pancreatitis is all the same? You have to give fluids.
Etiology or even sugar etiology, they're common.
Right.
Like hyperlipidemia or even escapiasis. So
Right.
such
Right. Okay. वो सब ठीक था. मैं सब सिर्फ पॉजिटिव फाइंड रखी था इसमें. Okay, because those short cases time भी हमारे पास कम था, इसलिए I've seen. ठीक है. So हमने when we saw literature that abdominal pain is very common, up to 40% patient comes with dengue pain. Yeah. Even with with gallbladder.
You will not find anything in literature.
Right. So, so we just saw the literature and, so abdominal pain is common symptom 40%. Diverse reason in patient with dengue fever could cause abdominal pain that we have discussed. Hemoconcentration, marked thrombocytopenia, 45,000 is marked thrombocytopenia to the evidence of plasma leakage, having greater opportunity of presenting with complications such as acute pancreatitis. So this is a, risk of developing acute pancreatitis in dengue fever. Furthermore, it is compatible with acute pancreatitis criteria, that is, amylase were raised, and it was accompanied by 3 times elevation in pancreatic enzymes, plus the findings of the hypoechoic pancreas on ultrasound, described characteristic of acute pancreatitis in relation to normal parenchyma. So, acute pancreatitis associated with dengue fever thought to result from a combination of direct factors like viral effects, immune-mediated mechanisms, and hyperperfusion or ischemia due to dengue shock syndrome. Right? So there are some proposed mechanism was seen in the literature that direct viral cytopathic effect. It could be because of immune response and cytokine release. It could be due to endothelial dysfunction and vascular leakage, hematologic disturbances like thrombocytopenia, coagulation abnormalities, and secondary infections, as Dr. Vijay pointed out. Secondary infection and organ stress can lead to this pancreatitis organ damage, including pancreas. So cases are there, but it is not very common, right? So it is uncommon. So although dengue virus infection may share GI symptoms with acute pancreatitis, differentiating factor in this case is the presence of elevated pancreatic enzymes, which do not occur in dengue fever alone. If they have dengue fever, the pancreatic enzyme doesn't go rise so much. Accompanied by ultrasound findings, with direct diagnosis to acute pancreatitis with dengue virus infection, given the positivity for dengue NS1 and IgG positive at the initial evaluation. So we make a diagnosis of dengue pancreatitis, and treatment is routine conservative management, fluids, and antibiotics are role, I don't know, but normally some लोग देते हैं antibiotic. So I don't know what is the role of antibiotic, Dr. Anish.
One, acute pancreatitis, no role of antibiotics. If being done, that is a different issue, but universally they are
This is not the case. This only up to 4 to 6 days when you are basically having nature or when basically having to maintain a basically level of about 40 to 45. Day 5 to day 6 are very crucial.
Yes.
We should not give fluid and we necessarily fluid and we should say the fluid with and not always because by giving more and more fluid, we are sending the patient towards police society and then the complications.
Absolutely right.
The point is, this patient does not show.
No, sure, not sure.
All patients who are having monocytosis, they are having shock-like syndrome because monocytes are having this type of viruses. And when monocytosis is there, they liberate more of the cytokines, and they are responsible for shock. So which is not present in this.
Okay.
So we should find out the other cause for. Have you sent any EBV incident?
No. So Anivita, your comments on this particular case?
It's a very, very interesting case. Actually, so last week we encountered a very similar presentation with us also. So similar presentations are day 6, day 7 of dengue fever, where the fever had settled and patient was in severe hemoconcentration and patient had recurrent vomitings and severe abdominal pain. And here, sir, like you pointed out, monocytosis was a trigger for an inflammatory response phenomenon in this patient. However, in our patient, we had hypercalcemia. So because of acute dehydration, our patient had presented with hypercalcemia, which had triggered the acute pancreatitis. So, sir, like you reviewed the literature, there can be cytopathic phenomena because of the virus itself. There can be immune response, which can lead to high monocytosis, inflammatory markers such as ferritin, CRP, LDH. These will be very highly elevated and which can induce pancreatitis. Or simple dehydration leading to hypercalcemia can lead to hypercalcemic pancreatitis. So all these end organ damages and immune cytokine release phenomena are very common in the day 5 to day 7, where when our platelets start to fall and when the fever is gone. So critical fluid management and critical end organ preservation with a lot of hydration and monitoring is the key here. So, and as Dr. Naresh said, there is no role of antibiotics. And thankfully, despite of all pressure by the family members, we did not give any antibiotics to our patient either. And within 4 days, the pancreatitis, the fluid, and overall the patient's general condition had completely resolved.
That's great. I think The second point is immune response and cytokine release. That's very true that these patients have monocytosis. So possibly that cytokines would be a trigger to that acute pancreatitis. That's very true. Dr. Arora sir, you want to?
The patient, one of the patients who are having dengue fever, and later on he was found to have salmonella typhus. So in such conditions, if you provide the patient of antimicrobials in the first 5 days, then what will happen? Is it medically right that we should give patient such patients,
So it's
especially patients who are having fever even after 5 days of illness?
right. So it's a very intriguing question, right? To avoid antibiotics. This patient, our patient was not having any fever after 5 days. So patient fever was subsided, right? And it goes in tune of what dengue fever goes like. Patient 4 to 5 days high grade fever, 103 max, and after 6 days, patient was absolutely febrile. So at that point, and we just send all the cultures, like we send urine cultures, blood culture, everything. Right.
We have raised more stress in the monocytosis. Any patient who are having 40% monocytosis and having a normal course of dengue fever, this is less likely. Because we should find out some other cause of monocytosis.
So I think every patient different. That's why it is atypical. And patient, fortunately, patient got better off with IV fluids. You are absolutely right that we don't give rush of the fluid, but PC was 48, patient was platelet was 45,000 at the point. And patient seems to dehydrate it. So we just gave fluids, and after 14 hours of fluid therapy, patient got better, pain got better, and we had that diagnosis of acute pancreatitis. And we already said acute pancreatitis treatment is fluid, dengue fever is treatment of fluid. You have to closely monitor the PCV, the hemoconcentration, the hemoglobin level, right, and the platelets. And accordingly, we have to adjust our fluid therapy, because if we crush fluids, and patient definitely go to most of the complications. So, Robert sir, you want to comment?
I think what Vijay is saying is correct, because people who are sitting in the tertiary care centers, like ours and facing others also, I think many times we are getting patients who have fever for a couple of days. Many times you get patients who come to you on day 1 of fever. And also there is a feeling among the clinicians that for the initial 48 hours and some say for the initial 5 days, do not do any investigation. I don't know how far it is correct. That situation, people who are coming to us, they have missed us many times. So there's many times the diagnosis is very tough.
Right.
And this situation, Vijay has pointed out, this is not very uncommon. You do see patients because they have fever a long time, and suddenly the fever is high. You say they should have diagnosis, but then you forget that there was something else going on.
So their literature, yes, sir.
Investigation with the trial patient, when there is suspicion, one must not do.
Right. So literature also says that dengue fever, because there's a term like expanded dengue syndrome (EDS), where dengue fever present with co-infections and comorbidities like malaria or enteric infect. And I think Dr. Vijay is going to present such case, complex febrile case, where multiple sites of infection there, and sometimes very difficult, which is the primary infection, right? So we have to be monitor those patients. As the patient was not having any fever, if he was subsided by 5 days with evidence of acute pancreatitis, the patient started settling down. The patient was settled on heavy running fever, definitely we could have start treatment very aggressively in those patients. So this is our first case, and I'll take only 5 minutes for the second case, which I came just few days back only. So this is a 38 years female presented with on 2nd October 24 with chief complaints of high grade fever, multiple episodes of vomiting, generalized weakness, burning micturition. And she was saying that patient having blood in urine. So we thought sometimes a patient 38 years, sometimes bleeding PV, sometimes is confused with his bleeding urine. So I said, okay, could be because in dengue fever, menorrhagia and bleeding PV is very common, right? So we just asked the patient to have the urine in the tube or this vessel so that we can see that. And when she collected, the accurate was hematuria, right? So this was the presenting complaint of those patients. Okay. Second patient, sir. Right. So वो patient क्यों ऐसा discharge हो गया सर वो सबको settle हो गया everything. Pneumonia में होता है सर क्या टाइम में nothing.
Patient record without antibiotic or with antibiotic?
सर tertiary care में कौन सा patient बिना antibiotic जाएगा सर? लेकिन यहाँ पे एक्चुअली निमोनिया हो जाता उसको पहले, कल्चर में स्टार्ट था। Right. So, second case, so patient was apparently well 6 days back when she developed symptoms of high grade fever, 103, not a severe chills, burning micturition was there, multiple episodes of vomitings and not able to exit orally. Frank blood and urine since morning since जिस दिन आई थी तब से उसको urine में blood आता है. So what could be the possibility in this particular case? अगर आपका patient आएगा तो that what you will do? It was painless hematuria. Burning was there, not dysuria. The dysuria was not there. Only burning with hematuria. Female cell. 38 years. So if we just got this test done on seconds, platelet was around 1.6 lakhs. So I think this is not thrombocytopenia. TLC was around 3.12 as Dr. Vijay rightly said. Most of the patients have leukopenia. Urine culture routine is RBC is full field and pulse cells were around 100 per high per field, right? So maybe some co-infection, some UTI is going on, some cystitis going on. I don't know what's happening. So dengue NS1 came out to be positive because if we do by ELISA, so it comes after 24 hours. The NS1 positive. Platelet count was didn't drop too much at day 2 with 1.45 lakhs. TLC again 2.5, and we did the INR also. INR was normal. So the patient is not having any coagulopathy or something like that. But hematuria was frank. That was sure, and we were quite scared about that. At what is going on. Sometimes this type of hematuria or bleeding disorder we see severe dengue. When the patient goes into DIC and complete dengue. But in normal patients, sitting in normally talking and having hematuria, so we were quite skeptical what's going on. Yes, 100 per 100 per. With leukopenia, sir, with leukopenia. Normally, suppose infection होगा तो leukocytosis कुछ होगी, but 100 per cells, I don't know. So besides all culture, blood culture, urine culture, so ultrasound we do this, right? So on examination, predominant some EPS tendon was there. Diagnosis we made a dengue fever with thrombocytopenia with hematuria with UTI. This was our diagnosis, and ultrasound was absolutely normal. कुछ नहीं था उसमें. हमने बोला कि देख लो कुछ स्टोन मिल जाए कुछ मिल जाए तुमको, बिल्कुल नॉर्मल था. 3-4 बार बोला इसको, तो फिर हमने कहा चलो सीटी कर लेते हैं because sometimes stones and all that. CT भी किया वो भी ठीक था सर. तो NCT QB was also normal. So we were quite perplexed. ये blood कहाँ से आ रहा है इसको with normal platelets. 1.45 would not feel that इसको इतना hematuria होगा. And frank hematuria. Urology friend was sought in view of persistent hematuria. अब उसमें क्या करेगा urologist? They said, okay, boss, you start conservative treatment start करो. You can add Nextamic acid and just watch. Anita, you want to say something?
Sorry, sir. I was just asking, what are the renal function tests like?
Pardon?
RFT.
Sir, मैंने सब यहाँ पे कुछ normal लिखा है. Everything was normal. Functions, everything was normal. I just mentioned only abnormal findings in this particular case. So everything was normal. Patient was hale and hearty, right? कोई complaint नहीं उसको, बस सिर्फ hematuria आ था उसको. And patients के attendant मुझसे बोले थे इनको रखा क्यों हमने? Why we are kept? So I am worried that patient is having hematuria. Patient, and the thing is that का platelet with बहुत ज़्यादा ड्रॉप नहीं किया है, hemoglobin बहुत ड्रॉप नहीं किया उसका, right? So it's very strange. So course in the hospital that hematuria persisted, burning micturition was there a bit, abdominal pain persisted. Hemoglobin dropped a little bit on day 2 or day 3, 14 from 30.5. Platelets was around 1.4 lakhs, and TLC leukopenia was there. And we started on tablet. The next one I said patient was absolutely normal. So on day 8 of illness, hematuria was there, but going bit down a little. Burning micturition at 10%. Hemoglobin dropped a bit also 12.4 on day 8 of illness. TLC started rising from 2.5 to 3.8, and platelets around 110, 140. Patient was stable and patient was absolutely normal. Just only complaint that patient is having past blood in urine, and they just persistently saying that please discharge my patient. So I said that if the patient is having hematuria, right? Patient having hematuria, how can I discharge the patient? Can I don't have any problem. Why you are keeping me in the hospital? Right. So सब कुछ ठीक था, उसमें सिर्फ RBCs थे, इसमें no cast, no abnormal cells, pulse cells थे 100 पर, तो हमने कल्चर भी कराया, कल्चर came out to be sterile, but इसमें हमने एंटीबायोटिक दी थी हमने, because 100 cells थे, तो we have started antibiotics. ठीक है, I must say that, and patient after 4 to 5 days, patient fever settled down, hematuria was there, but decreased intensity, burning micturition and abdominal pain also decreased intensity, urine and blood culture did not have any growth, and patient was discharged on request actually. मतलब उसको hematuria हो रहा था अभी भी, but patient was discharged on request. Okay, I am perfectly fine. Why are you keeping me? Just discharge. I just give him writing that hematuria is there and we can discharge the patient. Sir, सब करा ली सर. देखो कुछ नहीं था उसमें, हम लोग तो बड़े इसमें कंफ्यूज हो गए इसमें, क्या हो रहा है इसमें. There was nothing, gynecologist, urologist सब देख लिया, nobody could make out कि ये blood इसको कहाँ से हो रहा है. अब इंटरवेंशन तो करवा नहीं सर, सिस्टोस्कोपी तो करवा नहीं इस पेशेंट में, बिकॉज ऑलरेडी डेंगू है, लो प्लेटलेट्स. तो हमने कहा भाई ऑब्जर्व करते हैं इसको. Hematuria, पता नहीं, I don't know, the patient come in OPD and just see what will happen. The patient will discharge and request.
Sir, did you
1.45 lakhs platelets हैं.
sir, did you try bladder irrigation?
कुछ नहीं किया हमने, we didn't do anything. But hematuria था उसको, frank hematuria था, हम लोग रोज देखते थे क्लियर करके इसको. So I thought कि सिस्टोस्कोपी करें.
Might be having some bleeding focus, maybe some ulceration that is not picked up, and there is always a qualitative defect in the platelets in cases of the dengue.
So what I said on that day कि
Defect, that
right.
is-
Right. What I said that patient needs some intervention in the form of cystoscopy when the patient settle down, the hematuria is settle down. But if the patient becomes better, I think the patient would come in my OPD, definitely hematuria, then definitely will do the investigation. But as such, patient is absolute right. I don't think so. कि कुछ उसमें होगा. So just pure,
What was the?
you know, this कुछ पता नहीं लगा था.
Why didn't you?
कुछ नहीं बोला उन्होंने कुछ. Right. So मैंने कुछ देखे थे लिटरेचर. Sir, I saw the literature के right. Sir, only 2 slides. 2.
Actually, small polyps or
कुछ भी होता है.
some lesions cannot be picked up by CT scan.
Yes.
Spectroscopy.
Yes. So we have taken note. Which journals I could find out? There is some Saudi journal. There is some literature with Saudi journal, sir. लेकिन ये मुंबई बेंगलोर के हॉस्पिटल का डेटा था उन्होंने. So they have seen some data around 2,500 patients coming with dengue. They actually screen kidney involvement in dengue, and to our surprise, kidney involvement is not very common in dengue. Unless the patient goes on dengue shock syndrome, the patient stable patient with normal platelets, the kidney involvement, why the kidney involvement there, right? The patient is having AKI or some, some DIC or some dengue shock syndrome. People suspect AKI. So they have seen in normal platelets with kidney involvement. So they see that 8 to 10% of patients with normal platelets had some kidney involvement. 10% patient. There's few patients came with AKI, some with glomerulonephritis, which was dengue-related infection-related glomerulonephritis, and other was having hematuria, but they were macroscopic hematuria, not gross hematuria. Other literature was present in Indian Journal of Urology, but this is doctors from Thailand. They have seen almost 84 cases of this microscopic hematuria, and one case there is gross hematuria, and they also could not find anything. And after 8 to 10 days, the hematuria subsided. So they were not cystoscopy, nothing was done, and after 10 days of treatment, patient blood was subsided. So possibly our case was similar to that of this patient, that without any invitation with normal platelets, the hematuria subsided. So what was the reason? We could not able to find it out. So I think this is the case, and just one line that WHO to do spectrum of expanded dengue syndrome in 2012, right, with atypical and unusual manifestation of neurological, renal, hepatic, or other isolated organ systems, which occurred as a complication of severe profound shock or co-infection. So secondary to underlying post-condition disease. I don't know what would be there. GI involvement could be there, like cholangitis and acute pancreatitis, renal involvement like acute renal failure, ATN, HUS, cardiac involvement like arrhythmias and myocarditis, respiratory like pulmonary hemorrhage. So we used to see those cases, but not very common. And HLH is also a very dreaded complication of dengue. We have seen in last epidemic, 2 or 3 HLH, and it is also there in dengue fever. So with this, I thank you very much for your present hearing. And this is the 2 unusual cases that I thought that I used to discuss with you all. Thank you very much. So it is very uncommon, sir. Very common, because normally we see Dr. Vijay said that normally patient with leukopenia and lymphopenia, but monocytosis of 40%. Actually, it is abnormal. It is unusual.
Another study, who had monocytosis, they had hemorrhagic shock. They were in baby shock syndrome, who had monocytosis. So it's not a very common thing. Whenever it is there, infection is national issue.
Can it be considered as a major sign?
Mostly marker for baby shock.
So Anvita, your closing comments on this case?
Yeah, what question to Anvita?
So both cases are very interesting. So as you mentioned, expanded dengue syndrome is a new entity. And so last year we found a lot of cases with frank acute liver failure and HLH with dengue without thrombocytopenia and just dying within 3 to 5 days. So it is quite a risky scenario. So all we have to do is very close clinical monitoring of these patients. And regarding thrombocytopenia management or bleeding management, there's just one comment I would like to make. I had seen a lot of dreaded complications with clots and having the need of even nephrectomy at times, because we don't know whether the hematuria is coming from the bladder, whether it is coming from the kidneys. So if there is frank hematuria which is arising from the kidneys, there can be sudden clot formation which can lead to papillary necrosis and severe obstruction. So I would leave this open to discussion with all the seniors, that what is their experience with tranexamic acid in patients with hematuria? How do they manage it?
I request Dr. Makkar to felicitate the chairperson's model and the presenter also. Our next case is diagnostic dilemma in a complex case of febrile illness. Presenter is Dr. Shrishti Kansal, second year DMB resident, Max Specialty, Max Patparganj. The case is being moderated by Dr. Vijay Arora, and it will be chaired by Dr. Rajiv Bansal and Dr. Anvita Agarwal. Kindly start with the presentation.
Good afternoon to one and all present here. So, diagnostic dilemma in a complex case of febrile illness. So, a patient, this is the first case. A patient was a 29-year-old female resident of Delhi and engineer by occupation, Hindu by religion. She was admitted with us on the date of 15 September 2024. She came to us with the chief complaints of pain abdomen since 20 days, high-grade fever since 7 days, nausea and vomiting since 3 days, and yellowish discoloration of skin and eyes since 2 days. This is the history of present illness. She was apparently asymptomatic 20 days before admission when she developed pain abdomen along with fever. Pain in right upper abdomen was insidious in onset, gradually worsening, dull, aching type of pain, non-radiating and not associated with any aggravating or relieving factors. It was associated with high-grade fever and chills, maximum temperature up to 102 Fahrenheit. Fever was intermittent type and no diurnal variation was noted. It was relieved on medications like PCM. For aforementioned symptoms, she visited a local practitioner. Fever lasted for about 2 to 3 days and then got relieved, but again abdomen persisted, for which she took painkillers on and off. No.
Can we go back?
Yes, sir.
The previous slide. First was pain abdomen.
Yes.
And after 13 days of the pain, the fever started, right?
So, sir, initially she had pain abdomen along with fever. Fever was relieved in 3 days, and then her pain abdomen persisted, and then she again had fever.
Pain abdomen, along with fever at the start of the disease.
Yes,
Fever got relieved after 3 days.
yes,
Pain abdomen persisted.
persisted.
After about 13 days of that,
She again had
she
fever.
developed high grade fever.
Yes,
That's how this is.
yes.
The high grade fever, with loaded grade fever,
Uh.
high grade fever means more than 100 fever. Loaded fever. Never goes in that.
So then about 7 days before admission, that is 13 days after onset of symptom, fever recurred. Fever was again high, matlab up to 102 Fahrenheit, associated with chills, no diurnal variation. There was no history of cough or cold, loose stools, increased urinary frequency of burning micturition, no history of joint pain, rash anywhere in the body, contact with animals or pets. Patient also noticed yellowish discoloration of skin and eyes 2 days prior to admission. It was also insidious in onset, gradually worsening, and associated with nausea and vomiting. There was no history of weight loss, loss of hepatite, night sweats, no history of any hepatotoxic drug intake like ATT, no history of tattooing, blood transfusion, or any high risk behavior. She got some routine tests done for these and was admitted to Max Patparganj Hospital for further management in view of persistent vomiting. There was no history of any abnormal lump in any part of the body, no history of abnormal behavior, LOC, headache, bleeding from any side. She traveled to Vaishno Devi in mid-July 2024, around 1 month prior to onset of these symptoms. And then there was history of drinking milk without boiling. No, she used to drink milk without boiling all the time, on and off.
Which type of?
Sir, she said that it was pasteurized, matlab the packaged one, but that was pasteurized, but we cannot be for sure that she never drank. So there was no significant past or personal history. Sexual, she has been married since last 1 year and no history of promiscuity. Menstrual and family history were also not significant. In the general survey, she was a 29-year-old, moderately built female, well-nourished and alert, conscious, cooperative, well-oriented to time-place person. Her BMI was around 24.9. Pulse rate was 112 beats per minute in right radial artery, regular. Okay, so her she had tachycardia. Respiration was normal on general examination, no lymphadenopathy, but we could notice icterus on eyes, oral cavity, mucous membranes, and skin. Head and neck, no significant finding. In GI examination, on inspection, we could notice yellow tinge over the skin, nothing significant. In palpation and superficial palpation, we could appreciate some RHC tenderness and soft consistency. Liver was palpable in RHC. Then in deep palpation, liver border is palpable 3 centimeter below right coastal margin and mid clavicular line. Liver span was 13 centimeters, smooth surface, soft consistency, tender, smooth margins, no pulsation, and it was moving normally with respiration. Spleen was palpable in the left hypochondrium, 1 centimeter, tender, sharp margin, soft consistency, and moving with respiration. Percussion and auscultation were within normal limits. Now, on the basis of the presentation and examination, these were the differential diagnoses we kept in mind, acute viral hepatitis being the most likely. We sent her workup along these lines. Her CBC was grossly normal. Her KFT, her LFT was deranged. SGOT was 425, 1200. These are when she admitted, day 1 or day 2 investigations. ALP was 224, GGT was 179, globulin was 3.2. Total and direct bilirubins were raised. HAV, IgM came to be positive here. HEV, HBsAg and anti-HCV were negative. INR, which is used as a prognostication. Keta was 1.2 initially.
Admission was which day of illness?
Sir, if we count 20th day from pain abdomen and 7th day from the new onset fever that she had. We sent malaria, dengue, typhoid, which were negative. Her urine culture showed E. coli and the colony count was significant. So we had to start her on antibiotics also. Ultrasound whole abdomen showed grade 2 fatty liver, moderate splenomegaly, and gallbladder, GP wall edema. Now, patient was treated as a case of acute viral hepatitis A. Antibiotics were also given as per the urine culture report. But she had persistent fever spikes even after 1 week of admission. So, in view of these fever spikes, we sent a tropical fever panel, which consists of scrub typhus, leptospirin, brucella, and EBV IgM to VCA was sent. CCT, HRCT thorax was done, and repeat cultures were sent. Obsgynic consult was taken and the examination was normal. HVS culture came to be sterile. Tab doxycycline 100 mg twice daily was added to the treatment empirically. Now, our points of concern in this patient was that she was having persistent fever spikes in spite of appropriate treatment. She had persistent pain, abdomen, and myalgia, persistent tachycardia even when she did not have fever. ECG was done. It showed sinus tachy. Echo was within normal limits. Cardiac enzymes were normal. So these are the reports of the test that we had sent. Her TFT was normal, sir. It has been mentioned. We got it done twice. She did not have any anemia also. Now, brucella IgM came to be positive. EBV IgM to VCA came to be positive. Scrub typhus leptospira were negative. HRCT was normal. CECT whole abdomen showed hepatomegaly and moderate splenomegaly. So she was diagnosed as a case of acute viral hepatitis A infection with brucellosis with UTI, urine culture showing E. coli with EBV co-infection. So now coming to the second case.
And which may be whether these type of investigation, yes, Brucella, because the history was pertinent, the patient was having unboiled milk and brucellosis may be one of the presentation, and the IgM was posted, which was significant. They started on doxycycline and we didn't start with streptomycin because we started beforehand when we were not subsiding, so we did not start with streptomycin. Although they have said that in Brucella, and we should give the dual antimicrobial streptomycin as well as doxycycline. So we started only doxycycline and along with the antibiotic which was taking ceftriaxone or UTI. These are the third one, hepatitis A. And patients with hepatitis A have this type of fever for 3 days, then asymptomatic fever phase for 10 to 12 days, and then the fever of 7 days. Could it be only a biphasic pattern of the hepatitis A pattern? So this is
No, biphasic pattern in hepatitis A is known for polystasis. Or the second phase leads to severe polystasis. It was not a second phase of
yes, there is no words.
But sir, nowadays for last few years, we are seeing patients with hepatitis A who have prolonged fever. Will not say becoming afebrile and then developing fever again, maybe co-infection. But because it is known in literature and standard education that hepatitis A will have fever for initial 2 or 3 days. But now we see patients with prolonged fever, 1 week or even 2 weeks, but that is a mild fever, not hypertension. So this was an afebrile period followed by a febrile period. But surprising that the source of infection, all these 3 infections is different. Hepatitis A is food-borne, or brucella is milk-borne, and UTI is different borne. So all happening together.
And those we private hospitals every day.
HIV status of
HIV was negative.
EBV happens in immunocompromised.
Nowadays, ऐसे patient निकल जाते हैं जिनमें range fever function होता है, we are getting around 20% patient with VC को ICU posting.
And what do you give for that?
Nothing, sir. The only thing I was asking was that if we start with gan cyclothrin or something and
So Anvita, did you go through this case and what is your opinion regarding this case? First case. Unmute kar lo.
I'm
Yeah.
sorry, can you hear me?
Yeah, it's okay. It's
Yeah.
okay.
So as rightly discussed, there are three aspects to this patient. One, hepatitis A, second, EBV, third, brucella. If we talk about hepatitis A, as rightly discussed, the pattern of hepatitis A has started to change. There is prolonged fever, biphasic fever might be seen, but it is much later in the illness. Like sir said, classically we used to read 2 to 3 days of fever followed by transaminitis. But now the fever and transaminitis can extend up to as much as 3 to 4 weeks also. But from second week onwards, if the fever is persisting, we must rule out other co-infections. Like in this case, we found UTI as another co-infection that the patient was having. So one must keep looking for other co-infections and treat accordingly. Otherwise, look for inflammatory markers. So secondary HLH in third to fourth week of hepatitis A with very high-grade fevers and toxic look is also started to become common. If we talk about the second component, the brucella, it is very interesting. And I think in the history, when she presented that the patient took unboiled milk, I think she had already started to point towards her diagnosis towards brucella. But it is important for us to understand that brucella diagnosis just alone by IgM is not a very strong indicator for the diagnosis of brucella. So ideally, brucella should be diagnosed on the basis of 3 parameters. One is the epidemiological history, like she mentioned, drinking unpasteurized milk or a very close exposure to cattle. That is, people who handle all the cattle carcasses like, placenta or all their fecal matter or even the postpartum, जैसे कुछ जिनके घर में गाय भैंसें होती हैं, they end up taking the delivery of the calf. तो वो postpartum का जो सारा material होता है, if that is not properly dispensed, then that is a big source of infection for brucella. So people who are handling cattle very closely, that is a higher indicator towards brucella rather than just drinking unboiled milk, because usually in the market we get pasteurized milk. Second, the second parameter for brucella diagnosis is standard agglutination test. So what we usually have in our labs is just plain brucella IgM, which has a lot of false positives and false negatives. So brucella SAT, that is the standard agglutination test, that is the ideal method, or obviously culture. The third thing that is important for brucella is any radiological findings suggestive. So here in this case, we did have hepatosplenomegaly, we did have transaminitis. So we may make a possible diagnosis of brucella, but it is not confirmed as per the current picture that I am understanding. Obviously, we cannot deny the patient of treatment. And sir, as sir rightly mentioned, we must offer 2 antimicrobials, an aminoglycoside or rifampicin, but because the patient had transaminitis, we can't give rifampicin. So aminoglycoside along with doxycycline. And because there is liver and spleen involvement, we would want to treat the patient for at least 4 to 6 weeks, not less than that. Then coming to the third aspect, if we talk about EBV, so EBV diagnosis by VCA and IgM is also a weak diagnosis. So these can stay positive for a very long period of time in patients who've had even small primary EBV infection like a sore throat or infectious mononucleosis. So in case we are wanting to attribute acute transaminitis because of EBV, the ideal testing method would be EBV PCR. So if we have EBV PCR levels very high, say to the tune of 3,000, 5,000, then that can give us an etiological diagnosis that yes, EBV transaminitis is probably what is causing the secondary fever, and it can predispose patient to further co-infections such as HLH or other acute bacterial infections. But in either case, offering the patient acyclovir is not of any use, or any other antiviral is not of any use with acute EBV. All we can do is just monitor the EBV PCR levels once in a week or once in every 5 days and see the trend. In case the patient is raising PCR copies of EBV to the tune of 2 lakh, 3 lakh, then we can maybe add a bit of steroids just to help the patient tide over the crisis. But overall, a very interesting case, a lot of aspects. I think this is the proper ID case that we would brainstorm over, and we would rethink again and again what are we treating and what more could the patient be having. Very, very interesting case and very nicely presented.
So now,
Ananta, and with one question, then once we have IgM VC positive, should we go for PCR in such patients to quantify or further treat the patient with steroids?
Definitely, sir. I would have. So, VC and IgM should ideally be done only in acute EBV presentations, that is primary EBV infection of like infectious mononucleosis, or just as a screening tool, sir. So here we could proceed with EBV PCR, but again that will not really change our management unless it is very high and the patient is very toxic, and if we want to give steroids. But short of that, we'll not be really able to give any other treatment to the patient.
Thank you.
now coming to the case 2, a 22-year-old female, a resident of New Delhi, student by occupation and Hindu by religion, was admitted to us on 28 September. She came with high-grade fever since 3 days, nausea and vomiting since 3 days, and yellowish discoloration of skin and eyes again since 2 days. Patient was apparently asymptomatic 3 days before admission when she developed fever. Fever was associated with chills, maximum temperature up to 102 Fahrenheit, intermittent type, no diurnal variation, relieved on oral medications. Fever was associated with pain abdomen, which was insidious in onset, gradually worsening. It was similar to the one the earlier patient had. She also had nausea and persistent vomiting, no history of cough or cold, loose stools, increased urinary frequency or burning, micturition, no history of joint pain, rash anywhere in the body, contact with animals, pets, or any insect bite. Patient also noticed yellowish discoloration of skin and eyes 2 days prior to admission. This was insidious in onset and gradually worsening. No history of weight loss, loss of appetite, night sweat, no history of hepatotoxic drug intake, no history of tattooing, blood transfusion, or any high-risk behavior. So she was admitted in view of hypertension and persistent vomiting. There was history of travel to some forest area near Lucknow 14 days prior to all this. Past and personal history were not significant. No significant sexual, menstrual, or family history. General survey showed she was a thin-built 22-year-old female, alert, conscious, cooperative, and oriented to time-place person. Vitals were within normal limits. She also had icterus, which was noted on eyes, oral cavity, mucous membrane, and skin. Head neck examination was within normal limits. GI examination on inspection, we noted icterus over the skin. Now palpation, IHC tenderness, liver was palpable, soft in consistency in superficial palpation, and liver border was palpable 1.7 centimeter below right coastal margin and mid-clavicular line. Span was 12.5 centimeters, smooth surface, soft consistency, tender, smooth margins, no pulsation, moving with respiration. Spleen was not palpable. Percussion and auscultation were normal. So this patient also, our differentials were more or less the same. Her labs showed low HB, which was iron deficiency, was found on further workup. Her LFT was also deranged. SGOT was around 4,000, PT was 3,000, ALP was 99, GGT, ALP was 153, GGT was 99, albumin, globulin 3.5, 2.4, bilirubins were raised. Her hepatitis A IgM was positive, and INR was 1.3. In this patient also malaria and dengue were negative. Ultrasound showed, her culture was sterile, ultrasound showed grade 1 fatty liver. Now she was treated as a case of acute viral hepatitis A. She also had persistent fever spike even after 10 days of admission. She had fever up to 101 Fahrenheit associated with chills. Tropical fever panel and EBV was sent in this case also. CTs were done. Obscine examination was normal. Tab doxycycline 100 mg PD was added empirically to the treatment. Scrub typhus IgM came to be positive. rest of the investigations were negative. So she was diagnosed as a case of acute viral hepatitis A with scrub typhus co-infection. In our examination, we could not find any eschar even when we looked retrospectively. So these are the learning points. Like
The causes of false positive. So she
Hmm.
now in forest area 48 days, everything that we take from there.
yes, as per literature, the incubation of scrub typhus could be 6 to 21 days. That could be a possible cause because in Delhi it's rare to see scrub typhus.
So there are a lot of false positives that are coming along with hepatitis A and E with scrub typhus serology. But a lot many times when the clinical picture is favoring that of hepatitis A or hepatitis E, very classically hepatitis, and then suddenly a scrub typhus serology comes weakly positive or just about positive. So one must confirm again with the lab for a repeat test because a lot of cross positivity and false positivity is seen in such cases. But it will be interesting to note. So after starting doxy, did the patient immediately improve? Because one of the other within 3 days, usually scrub typhus melts. Like if there is ARDS, if there is hepatitis, and if there is fever, within 3 days to 5 days of doxycycline, the patient is almost as good as normal. So did the patient have a very dramatic therapeutic benefit?
Yes, ma'am. She improved and she was discharged in around 2 to 3 days of starting doxycycline.
Wow.
She improved.
Awesome. That almost confirms scrub typhus. So one of the confirmatory tests for scrub typhus is therapeutic challenge. There are two such, interesting diseases in ID. One is scrub, the other is toxoplasma. That even if your serologies come positive and you give empirical treatment, the treatment response is so dramatic and so sure that it is almost like a diagnostic challenge. So toxoplasmosis and scrub, they melt with treatment within 3 to 5 days. So if the patient actually improved, then it's definitely a co-infection.
Dr. Nita, can we give doxycycline in cholestatic phase of jaundice, or we should avoid and give doxycycline that phase?
Sorry, sir, I couldn't hear you clearly. Could you please repeat, sir?
Can doxycycline be given in cholestatic phase? Because one of the indications of doxycycline is cholestasis. Can it be given in cholestatic phase?
Definitely, sir. Especially for scrub, this will really cause very good treatment response. So it can be given. However, along with doxycycline, what we need to do is monitor the liver enzymes. In case after the treatment initiation, the patient is experiencing worsening of cholestasis, it should not hamper our treatment decisions.
Thank you.
Thank you. Now I request Dr. Pankaj to felicitate the presenter and chairpersons in model.
Go ahead, go ahead.
Thank you so much for inviting me. Maza aa gaya. This such amazing cases. Very nice. Thank you so much.
Now I request Dr. Pankaj to kindly come over to announce the EDPA champion award for the month.
So I think the award was actually declared in August, but because of some reason, Dr. Grover could not collect it. So we are fortunate that Dr. Grover sir is here, and to invite anyone, we have to be a chairperson or speaker. So at least the person would actually come. So I request Dr. Grover sir to come over the stage, and I request Dr. Bijrawal sir, our Sandwich Chairman Committee member, to honor Dr. Grover with this plaque. Bijrawal sir. Dr. Boss. This one, come over. And he got the award because of the recognition of setting a highest clinical and academic standard in the field of medicine in the recent this event happened in Goa in August.
Well, this came to me also as a surprise, and I was invited for that. And there were about more than 50 clinicians from all across India who were kind of awarded and felicitated by these organizations for their clinical work and for their social work and for the various activities they have pursued in their career. I think this was amazing, and the function that the presentation was really very well organized at a national level, and you can see all who's and who of the persons who worked in the field of hypertension and cardiology and internal medicine. They were part of the whole program, and I think it is always very noticeable that whatever work you are doing in whatever capacity, this definitely gets noticed at some point or the other, and you do get the things recognized. It gives a very, very good feeling. There are many people who will be, they're so, let's say, visible. Like you find that screen presence of many people will be there. There will be different kind of persons. So that's what I also found there, that there were people who were known, but there were many people who we knew that they are very active in certain aspects. We are known, but in many areas, whether the social work or let's say preventive work or patient education, etc. I think these activities, they do get recognized, and there are various fora. So that's where it was. Thank you very much for to EDPN. Thank you, Pankaj, for this.
So I think with this, we conclude this monthly meeting, and thank you, resident from Max Patpaganj, for your active participation. And आपके हेयरसन खत्म हो गई हमारे में दोनों पार्ट आपके, and good comments and good inputs. And actually we learn from you all people, right? Because you see cases, and if you don't discuss, the knowledge is not disseminated. So the purpose of EDPA is that just bring out the support cases so that we educate ourselves as well, we educate others, that if the patient comes to us, we should not do any mistake, right? So I think, thank you everyone for attending this meeting. I think it's a good number today. So we wish that this meetings and these cases would present like these, and we will be more educated by you all people. Thank you very much for attending. Thank you. After that, thank you very much. And all the members of the executive committee would wait for our executive committee meeting in the first floor. Thank you.